Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, Behavioral Healthcare and COVID-19, the Next Phase. My name is Emily Moore, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast MHTTC. Before beginning, I would like to take a moment to describe the work of our center, followed by an introduction of today's speaker by Dr. Druss. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia at Emory University's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit our website to learn more about our center and our upcoming events. I'll turn it over to Dr. Druss so that he can introduce today's speaker.
Thanks, Emily, and hello, everybody. I'm really happy to present a friend and colleague, Dr. Lori Rainey. She is a board-certified psychiatrist and principal with Health Management Associates in Denver, Colorado. She's a leading authority on the collaborative care model and the bidirectional integration of primary care and behavioral health. Her work focuses on implementing evidence-based practices to improve the identification and treatment of mental illness in primary care settings and also improving the health status of patients with serious mental illness in behavioral health settings. She's the editor of several books, Integrated Care, Working at the Interface of Primary Care and Behavioral Health, and Integrated Care, A Guide for Effective Implementation, and has published numerous articles in peer-reviewed journals on topics related to integration. She was selected to be a master trainer for the American Psychiatric Association's Support and Alignment Grant to train 3,500 psychiatrists in the collaborative care model. Dr. Rainey served for 15 years as the medical director of a community mental health center where she fostered the development of a full range of evidence-based services, including the development of a telepsychiatry program, working in and deploying psychiatric providers in correctional health settings, managing the psychiatric medical team, and implementing prescribing best practices, including metabolic monitoring. She's worked with tribal populations with the Indian Health Service in remote clinics in the Southwest and continues her clinical work with the Utsi Mountain Utsi tribe in Tawaco, Colorado. Lori, I'm going to turn it over to you. We're really looking forward to your talk. Thanks so much.
Thank you so much, Dr. Druss. Let me get through the fun technology of Zoom and get this going for you. Okay, well, good morning, everyone. I'm really pleased to be here with everyone today and to talk about just a really important information around what's happened with behavioral health in the time of COVID, what that has looked like. We are now at about the 6-month point from the National Public Health Emergency announcement in mid-March, so almost exactly 6 months. Some of you may have attended the webinar that I did last May. We were about 2 months into it, and we were really trying to think about, you know, what's different, how do we think about mental health, what's happened. We had all sort of moved to, telehealth for many of our patients for infection control. We were really trying to sort through what was different and how to maneuver it, and it was really new. We're 6 months in now, and I want to say I don't have all the answers for today's conversation. So this is actually going to be very interactive, and we're going to take a time to really understand what's happening in your organization, so that you can actually share that information with your colleagues. So we're going to really look at where folks are in this COVID trajectory. We've got to think about it in terms of phases and what that planning process is moving forward. We want to really think again about those best practices for telehealth. It'll be really interesting to hear from you guys how many of your payers, Medicaid and others, may be moving or starting to move away from some of the telehealth services we were allowed to do early on. We really want to think about your staff. I would love to hear what's happening with them 6 months in. Are they coming back into the office? Are they nervous about coming back into the office? What's that looking like in terms of this? We're really, as we said before, COVID is not a sprint, COVID's a marathon. And at least through probably December 2021, even into the spring of 2022, this is our new reality. And we really need to think about in the long term what that's gonna look like. We're going to cover this and even more stuff today, so just hang in there. So here's the trajectory, and I want you guys to think about as we go through this, sort of where you are, because we're going to ask that question here in a minute. Let me pause for a moment. We want to get to know you a little bit, and we want to let's go ahead, Emily, and show that poll, because we want to really understand, what's going on with you. And what we want you guys to do is answer this for us. Who's your primary employer? And what's your primary job role? Just as a way for us to get to know you a little bit. So if everyone could just take a moment and answer these two questions, and then we'll pop up the answer here, just so we understand who's listening in to the webinar today. Okay, so a lot of folks, great, that are community mental health providers. That's where I've spent most of my life and my work. Great to have you guys on board today. And then we have a lot of folks that are in health education and clinical care, as well as administration. Great. And then we got some folks that are in others. So hopefully we'll get to hear a little bit from everybody today. Okay. Thank you for sharing that. I think that's our poll to get started with today. Okay, so what I want to do is think a little bit about this trajectory. In phase one, March 15th, all of our worlds turned upside down. We had to very quickly change the way we provide practices. We had a infectious disease raging out there that we didn't know very much about. We could hear from our colleagues in Seattle and New York what was going on, but the rest of us were really in that, oh my gosh, we got to get ready mode in other parts of the country. So we had this emergency response to all of this. Phase two has kind of been a recalibration, like, okay, when are we going to reopen our offices? How are we going to reopen them? Some restrictions have lifted in the 8 states that are in the Technology Transfer Center region, and we want to kind of think about what that looks like. And then there's phase three, where we're really understanding we're going to have wave 2, wave 3 of infections, hotspots are moving around. What is this really going to look like as we think about, as I mentioned, we could be December 2021, spring of 2022. What's our new normal going to look like between now and then? So let's see here. So as we sort of think about how we've scrambled, what we've had to do, sort of where we are in this process, many of you have had issues with, you initially had issues with a big drop off in revenue, which has been a concern. We've had to really think about, are we going to take temperatures at the front door? How are we screening our staff? How many doors did we close? Did we knock down walls in order to give us that physical distancing that we need with staff? And part of what we talked about back in May was a little bit of early lessons learned in this process. And now in sort of this phase three, some folks are beginning to actually move into whatever this new normal is going to look like. What are our new processes? What's our strategic plan? How are we going to manage our budget and operations? Many of you may have seen the National Council report back in May, June that showed 1 to 2/3 of mental health centers had about 3 months of funding available before they were going to be in trouble. There's been the CARES Act and other ways of thinking about how to help providers maintain, of all things, they need us hanging in there, because now we're actually have seen the CDC report. We're actually now seeing that bump in depression and anxiety that we were talking about. So here we are in kind of these phases, and what I'd like you guys to do is to tell us a little bit in the chat box where you see yourself in this, which phase are you in? Are you in phase 1, phase 2, phase 3, based on what you just heard? You may feel like you're a little bit between a couple, but go ahead and try to make a commitment to where you are right now. Okay, so 6 months in, the majority of you are feeling like you're in this kind of phase 2, 3, and so that real rebalancing and how do we move forward from here. Many of you still in that phase 2, and when we talked back in May, a lot of folks most of the people were actually in phase 1, and a few were moving into phase 2. So now we're kind of seeing this rebalancing and trying to sort of sort through where we're going to go from here. So thank you for that. Okay, so now let's begin to talk a little bit about, what's happening as we go through this. Back in May, it seemed like the major buckets of change, the key changes we were seeing with this public health emergency were around infection control. How are we going to protect staff? How are we going to protect patients? What is this thing called PPE? How much do I need to purchase for my clinic? What's this going to look like, and what are the protocols? So infection control, much of what we're doing is to simply try to contain a highly infectious virus. The use of telehealth then to be as part of that safe distancing and to maintain infection control. We really had to, HIPAA rules were relaxed a little bit, and even a little bit around 42 CFR were relaxed in order to have this protection. There was a lot of folks working from home, telecommuting. We've all had to get used to that. Some of us, what's it like to have Zoom fatigue? What is it like to treat patients over telehealth? How can we be sure about quality? How do we supervise our staff? We've had, there were a lot of financial challenges, as I mentioned before. A lot of you had to lay off or furlough staff. Then what's that like in terms of reimbursement for a while, as we took a big dip in terms of number of patients seen. Again, concerned about workforce emotional needs, patient emotional needs going through this, and really preparing for this behavioral health surge. Which was two things: current patients destabilizing and new patients really suffering from the effects of isolation, quarantine, and the scary time that it's been with a virus. What I'd like to do, so just kind of going back a little bit, these were the buckets that we were talking about 2 months into COVID. What I'd like you to do now, I have an exercise where I'd like to ask, what has been the most significant stressor that you've seen? Is it the ones in the slide I showed before, or has it been something different, something in addition to this, so we can make sure we keep our buckets of stressors current? If everyone would please type in your response in the chat box, and just try to, one or two of the highest issues for you in terms of priority in your organization. Yep. If you guys, if you hover your pointer over the bottom, you can actually get into the chat box and see what folks are seeing. There's issues around telehealth. There's issues around furloughing staff. There's issues around infection control, safe practices for staff. Great, great. Other thoughts? your most significant stressors as you've gone through the 6 months of COVID, keeping clients engaged, absolutely. The budget has been huge for most people. The working from home for sure. The community resources, yep. Not being able to have one-on-one connection. And how do we do that? Make that connection over telehealth. And what does that look like? Absolutely issues with morale and organizations, because I think a lot of folks thought 3 months and we're going to be out of this, and now we're starting to talk 1.5 to 2 years, maybe more, until we have a vaccine. So that's certainly an issue. Okay. All right. Yep. There's just a lot of things that have gone on. Okay. All right. So great. Thank you guys so much for sharing that. It looks like, thinking about the slide that I showed earlier, that many of these stressors are very similar to what we were seeing early on, and now we're sort of in the long haul. So now as you guys think about phase 3, this is the time in your organization to really think about your strategic plan to manage these issues that you just mentioned in the chat box, to begin thinking about, all right, how are we going to manage these? Because I don't think we can just sort of stay where we are and hope and wait for things to get better and go back to normal. But I think the challenge for all of us is, what's the new normal? And really kind of thinking about that. So many of you probably saw the CDC report. The link is on the bottom for those of you who want to take a look at that. But what we're really seeing is, 40% or more of adults really experiencing an adverse mental health or symptom because of the virus, the pandemic, what we've had to do. I don't know about you guys, but I'm ready to go to a movie theater and out to a restaurant to eat. I'm in Colorado, and we're really, continuing with many of our restrictions. We've had folks that are considering suicide, and it's higher than it used to be. So we've got a lot to manage in our community mental health centers. Depression, really people thinking or having the symptoms of depression being almost 3.5 times higher than in 2018. So we had 2018 data, and now we really have current data. Then this was data taken from the time when people were in what was going on with COVID. Our essential workers, that includes us, the clinical folks, are really having a difficult time with substance use, coping, and thoughts of suicide, depression, because it's relentless on the front lines in terms of having to continue to take care of patients and still have your own life and your own concerns and fears about the pandemic. And all of us have heard about the incredible disparities in who's getting COVID, who's dying from COVID. What does that look like? I'm down here by the Navajo Reservation. We have certainly had a spike here, and in many of your communities where there's there's more poverty, lower socioeconomic status, we're absolutely seeing a higher rate of deaths and infection from the disease. So we have all kinds of things, really going on. We have COVID-related trauma that we really think about, due to the effects of isolation, quarantine. I don't think it's as traumatizing to have our kids home from school, although I've heard that is extremely stressful for parents. Luckily for me, my daughter's in college, but I can imagine a couple of young kids running around behind me as I'm trying to do this webinar, and how difficult that has to be when you're trying to do your job. Again, we mentioned that 3.5 times higher rate of anxiety or depression, and we're also seeing people using more alcohol and other substances to cope. These are some things that we sort of predicted when we talked back in May. Now we actually have the data to back it up. The thoughts of suicide, what I want to you guys to sort of think about, it's in that group of 18 to 24 that has really caught us off guard a little bit, but it's not surprising if you think about it. And again, my daughter's caught up in this group. We have a lot of folks that graduated from high school, graduated from college. They didn't have prom. They didn't have graduation ceremonies. Their job, a lot of jobs that they had applied for either got canceled, put on hold. Their future, their life, that kind of what's been going on with them is really, really disrupted. We're also seeing it in that 25 to 44 age range. So we've got 1 out of 5 people with who have thought about suicide in the last 30 days. And what I'm hearing from community mental health centers is this is a group that, you know, they're coming in. We've actually had some suicides, and it wasn't like there was an appointment and we were worried about them. We had a good session, and the next thing I know, I've heard from my staff about a suicide that I didn't even expect. So folks are saying, gosh, how do you work with this 18 to 24 year old group? You know, what does that look like? And I'll be curious what your experiences are. So the things that we predicted back 2 months into this are actually happening. And the CDC report from June is alarming but expected. And then the question is for you guys with staff morale, people working from home, budget issues, how are you going to gear up? How are you going to change your practices so that you can actually deal with this surge not only of new patients, but of existing patients who've had a tough time? Now, that's what the CDC reported in a national survey. Most of you guys are in the Southeast who are working with the Technology Transfer Center. So I'm just curious, does your experience match what we're seeing from the CDC? So if folks would just take a minute and fill this in. Is it depression, anxiety, suicidal ideation, PTSD, substance use, like we've been talking about? Or are there other things? I'm assuming you're all seeing this. Are there other things that you're also seeing that you can share with your colleagues on the phone? Is there anything that we're missing? For instance, are you guys seeing a lot of struggles, decompensation with your SMI population, for instance? Are there other groups, or are there particular ethnic groups, racial groups that you have noticed significant changes in? So let's just sort of get a feel for what folks on the phone, what are you actually seeing in your practice? Lots of substance abuse, that escalating violence at home. There was actually a prediction of increases in domestic violence in particular, and child abuse. People are, you know, in their homes and really struggling. Yep. So the anxiety for sure, super, super high. And in the other box, we're having people sort of put, you know, in the chat box some of the other things that they're experiencing. Good. Okay. Family violence, absolutely. So that gives you guys a sense in your organization, what is it that you've got to be geared up and prepared for? And really, this is what you're already doing. Food insecurity, the food banks are over the top with having to provide. I've actually been packing boxes down at our local food box, and we have just never had this many people in our small community lining up at food banks. Okay. All right, guys, thank you so much for your responses. This is really helpful in terms of that level set and thinking about what we have to gear up for and how are we going to provide services differently. Many of you don't have an abundance of staff sitting around waiting for a surge of behavioral health patients coming in. So what's that going to look like? So let's just kind of look at some of these buckets that we talked about last time and kind of go back 6 months into it, what's happening. So when last time we talked a little bit about what's going to be tossed, what we're going to keep, what have we learned? And believe me, our federal agencies, our state agencies, we were thrown into a telehealth experiment after years and years and years of payers, regulatory agencies really hesitating, not really letting us expand telehealth, even though we had proof that it worked. We have all kinds of evidence and research for years showing that it worked. There has been very low uptake, and overnight, there was a huge jump in uptake, as you guys know. What we're hearing is that state Medicaid agencies in particular, I don't know about you guys, but I have really enjoyed the ability to use the phone to call my patients. When I go out and work in my clinical work on the reservation, I had 18 patients on my schedule the other day. I got hold of 16 patients and had my appointment, was able to bill for that, and it's the highest show rate I've ever had. For patients, and not show up in person, but actually answer the phone. Most of the time, I have about a 50% show rate out where I am. We were able to really overcome barriers such as transportation and gas, but unfortunately, these are going to go away. If you think about it, phone appointments might be an area where it's called fraud, waste, and abuse, where things could potentially happen. And so most of the state Medicaid agencies and Medicare, you guys remember, we've been able to do these with Medicare too. Most likely those are going to go away. The video conferencing, not so much. what we're seeing is there's probably going to be an allowance and continued allowance for video conferencing so that we'll be able to get paid for that. So that's just one of the things that happened that we talked about last time. We weren't sure what was going to happen. With the DEA, we're still waiting to see. If you guys remember, for those of you doing substance use, MA, who are doing medication-assisted treatment for opioid use disorder, the DEA used to require an in-person exam, which really first, before you started a telehealth visit. We're still waiting to see how they're going to rule on this. They're concerned about diversion. If they can actually see someone, if you could see someone in person, and you kind of know who that person is, good chance this isn't someone who's just sort of tricking you over televideo. But that actually, as you guys know, really limited our ability to provide substance use services. And in the middle of this, opioid epidemic that's really been eclipsed by the COVID pandemic, we really going to need to pay attention to, is there going to be a spike in opioid overdoses and what that looks like. So we're still waiting to see what the DEA is going to do. We have absolutely learned that we have to prep our patients, and there are many handouts available. A really good one I found is on the SMI Advisor website. Our patients are in bed with the covers over their head. They're in grocery stores. They're in their car. They're in busy places. And that's not really being prepared for an adequate and secure, and from a privacy standpoint, appointment. So we've really had to think about how to prepare our patients for televideo, calling them the day before. If there's an app like Doximity or DoxyMe or Zoom or something they have to download, how do we actually prepare them for the use of the technology? How do we engage them? There seemed to be a really good engagement. Initially, it was all new. People were scared, and now we're actually seeing a drop-off in engagement, that folks aren't answering the phone or tapping into the televideo. So what is it that you do? And many people mentioned that problem with that personal connection, and how do we do it? Our staff need to be ready. They need to be dressed and appropriate when they're on the phone or video with a patient. So how do we make sure our staff are actually prepared for these visits? Their kids running around in the back, the dogs barking, the cat walking across the keyboard. Most of us have at least one story to tell about seeing patients. Patients see in your background, or do you put up a different background or screen, those sorts of things? What does the workflow look like? Do I have someone call them the day before? Do I call them the morning of? Do I have my MA? If I'm a psychiatrist, do I have an MA or someone call? My primary care doctor had her nurse call me before a visit the other day, and I had to pull out my husband's blood pressure cuff, my scale, and my thermometer, and actually have vitals ready for her. So it's just kind of interesting. How do we actually think about our workflow? Volume dropped off, and then volume picked back up, but now with the lack of engagement, what's the volume of telehealth? We're noticing that folks can actually do a more efficient appointment. Instead of the 15 to 20 minutes I used to have, I'm finding in about 10 minutes, especially on the phone, I can cover what I need to cover. So what does that look like in terms of volume? We have to really figure out who gets telehealth and who doesn't. Many of you mentioned there are patients that are missing that personal touch who need it. We're seeing post-traumatic stress disorder, serious mental illness. There are these subgroups, these groups of patients that we really need that personal touch. And actually had one of my guys with schizophrenia, we had him show up at the back of the clinic, and I walked out and talked to him with both of us having a mask on, because the telephone thing just wasn't working. I needed to lay eyes on him. And then what's the ongoing payment going to look like after the public health emergency? Again, for televideo, for teleconferencing, we're expecting, especially for Medicaid and Medicare, that some of that will continue. For phone calls, probably not. So that's what we've kind of learned. So let's just talk a little bit. Many of you were just getting started, just getting your feet wet with telehealth. Let's, in the chat box, let's have you talk a little bit about what your experience has been of telehealth. And absolutely, this whole issue of clients not having the technology is going to have to be addressed, especially if the phone calls go away. So everyone, just, has it been positive, negative, mixed? What's going to happen with telehealth? Many of you are bringing your staff back in. So let's just talk a little bit about that. And you can put something in the chat if you want to explain or talk a little bit, especially if you're unsure about what's going to happen. So everybody just kind of fill this poll out real quickly. And I absolutely agree with Richard about, I really wish the telephone visits could continue. I absolutely agree with you. Okay, So yeah, absolutely a mixed experience. And it's really good to see that many of you are planning on continuing telehealth, and no one said absolutely no. So this is a huge change for your organization. And this is going to be moving forward. So in your strategic plan, maybe even having a telehealth task force, what does that look like in terms of maintaining this because of the negative experiences, patients not having the technology to do this? What's going to happen when those phone calls go away? Are we going to have to go out and put a smartphone in their hands? What does that look like? We got to really sort of problem solve what's going to go on with that. So I would really encourage you to set up a telehealth task force. Okay, and then some of you aren't sure, and that's absolutely, we don't even know what all the payers are going to do yet. Okay, yep. Okay, good. So your telehealth experience is very much like the rest of the nation, and again, you got to be prepared for this being more of the long haul than just wishing it would be over sometime soon. Okay, so, and many of you answered this, but let's just go around again. How are your patients responding to this? What are the obstacles? So some of you've already said that the patients don't have the technology. They don't have the iPad. They don't have the smartphone. And what we're actually seeing is case managers masked up in inappropriate PPE. You got to have the protocols for it. Sometimes going out to patients' homes and actually holding like an iPad or holding a cell phone and allowing them to have their appointment with their psychiatrist or their therapist. So what does that support look like? So what are you guys seeing in terms of your patient's response? You've talked a little bit about your organization. What are your patients saying about, and this will be the telephone and video conferencing when we're asking this question. Yeah, something as simple as an email account. And there are issues about security that we've also seen around, patients in domestic violence situations, especially if the abuser is looking over their shoulder in the next room listening. All right, so patients, I think it's pretty cool that you've had some patients that have really, had a positive response around this. But for most of you, absolutely, the mixed response has been something that we've really seen. So we're seeing in the chat box now, really sort of what's going on, access to even peers having access to internet. That's another workforce you could tap into in terms of helping you to get out there and with patients in terms of sharing that technology with them. There's some comments around youth. I kind of missed them. It scrolled a little fast. Yeah, absolutely. Certain interventions. Someone called me the other day and said, can you do EMDR by teleconferencing? And I was able to find someone in the country that's actually doing it and get them connected. Okay. All right. So great. All right. You guys are having a very similar experience to what we're seeing nationally. And again, what are all those resources that will be helpful to you in terms of overcoming these obstacles, both for staff, technology, patient adoption of this? What does that look like? And I heard from some primary care providers, they're doing kind of an every other appointment. So one appointment telehealth, one appointment by video conferencing. And again, that's what my primary care provider's been doing with me. I've heard MAT providers doing that for opioid use disorder. We got a lot of home inductions going on, and then trying to make sure that next appointment, if we can, is in person. We've got places where there's surges in COVID. It makes it a little hard. You might have starting to bring patients back in, having your staff appropriately protected, and then a surge occurred maybe in Florida, other places. You guys have seen this, and then you had to back up and do things differently. So you're going to see that. Be prepared for that ebb and flow. Don't be discouraged when it happens. We assume when everyone comes inside with the heat, with needing heat because of the cold environments, you guys are, it's not as cold in the Southeast. I'm actually from North Carolina, but still people are going to come in. And what's that going to look like when they're inside and not strolling the beach and the parks and the roads and doing some of the things that they typically do? Okay. Now, let's move to your staff. We have all kinds of concerns. Staff were traumatized, patients were traumatized, furloughs, layoffs. Some of you even mentioned your staff not coming back. They're like, their staff, their nurses, doctors, people that have given up, they're not going to do healthcare anymore. This was too frightening for them. It wasn't really something that they want to continue to do. They literally want to leave the field and go off and do something else. So let's just talk a little bit in the chat box about what are the emotional challenges your staff are currently have, and how are you handling it? I'd be really curious from an innovation standpoint. We heard a little bit last time about team huddles, meetings. In my organization, we do a Friday, we call it the water cooler gathering, where we at least try to look at each other, see each other on video chat. How are your organizations? What are you seeing? What are those emotional challenging with your staff, especially for administrators? And then what's that looking like? Yeah, absolutely. Staff are isolated, they're stressed, they're taking time off for a breather. They may have family members who are sick. Zoom fatigue is a big one. Child care concerns, kids not going back to school. I've heard reports of, I've heard reports of, needing 5 computers, 1 for me, 1 for my husband, 3 for my kids, who are all, taking, doing their school online. So that's really been a huge stressor for our staff. And, I've heard some places where staff were furloughed and they don't want to come back. Again, when the $600 unemployment benefit was going on, we really noticed for some of our line staff, administrators, and others that they almost made more money being on unemployment than they did in their current job, and they wanted to extend their furloughs. And with the financial stressors and things going on, it's hard to blame people for that, but we need them back and doing those jobs. People are worried about losing their job. If we can't bring in the money, what's going to happen? How do we connect with peers? And how do you really, the sandwich generation. I'm assuming that's the folks at home with young kids. My daughter just graduated from college, so luckily I'm not in that, but I'm certainly hearing from my colleagues in my organization about how difficult it is. And the other thing I'm noticing among folks is they're starting to turn their video off. Before, we kind of see everyone on the screen, and I think now people are fatigued with how they look, what's behind them, just kind of keeping that constant watchfulness. I had a guy on a televideo. He fell asleep the other day, a staff member. We might have been able to doze a little bit before, but you can't do that on Zoom and doing the kind of the video chat thing. So you're constantly on when you're on Zoom is something that I've noticed. You have to be very careful. Luckily, you can see yourself. So if your husband's walking around behind you or the cat's coming up or something's going on, you see yourself and you kind of know what's going on. So, okay, great. Thank you, guys. Now, and again, as you think about all this stuff going on, you guys have talked about, scheduling some meetings, what that's going to look like. And I'm just curious, again, about solutions. And there were a few in the chat. Most of you were really kind of talking a lot about, what's happening on the, what's been difficult for you. And I just really, we're going to talk in a little bit about innovations and the special things you're doing. I'd like you to come back around to this thought about, and even as you see your colleagues' chats in the box about some of what they're trying to do to make this, to help their staff get through this, to really kind of think about what you might do next in terms of, just really thinking about where you're going to go from here, because the issues with our staff and our patients aren't going to go away anytime soon. We have to learn. We're behavioral health people. We really need to learn and think about how are we going to do this differently in the environment that we currently have. We can't afford, if you guys remember that increases in depression, anxiety, substance use, we really can't afford to lose our behavioral health staff. We need to keep that income going. We need to help them with teleconferencing. We're actually seeing some staff that really like it. And I've heard from some psychiatrists, myself included, who have found they've got a higher show rate, and that there's a bit of a work-life balance. That time that you get to work from home, instead of say a 1-hour commute into Atlanta, for example, instead of having 1 hour there, 1 hour back, you're able to really be at home. And that folks are kind of saying, some folks are like, this is what I actually want to do long term. And so there's this, what we're seeing among your staff, we have staff that desperately want to come back. I have this in my office. I have staff that really miss the socialization. So I have staff that want to come back. I have staff that love being home doing teleconferencing. They'd rather stay and do that. So as you're doing some strategic planning, really think about, do we want to think about if someone really likes this and someone really doesn't, how do we think about which staff are going to do what, and then how they'll see their patients and how we maintain that quality. So again, some of your staff actually, they prefer what's going on. And how do you kind of think about who to keep doing the remote, who to keep in the office as you really continue that controlling of the infection rate and what's happening in your clinic. So it's okay to have that partial going on, but how do you think about who's good at doing it, who isn't, and how do you maintain that quality control? So definitely these things that we are seeing with our staff. So thank you guys so much for sharing what's going on and happening. We're seeing it in medicine, we're seeing it in behavioral health, we're seeing it in consulting, we're seeing it in technology companies, we're seeing it all over the place, that these are stressors, both the emotional piece and from working at home, that folks are they're really experiencing across many fields, unless this was your work. If you were working for a telepsychiatry company or you were doing teletherapy, unless you were doing those things before this started, it's certainly new, and as is remote work. And just really think about who's cut out for it and who isn't, because the folks that aren't cut out for it will probably quit unless we can figure out how to accommodate their preference as we go through this. As we learn more about infection control, I think we're going to be able to accommodate more in person as people want and need it. We just have to have the right infection control protocols in place. Some people are knocking down walls to really get that, some distancing. The therapy chairs were a little bit too close, and they really need to really think about architecturally, how are they going to make their organization safe so that some of their staff will be able to come back, and eventually all of your staff, and just what that might look like. And even as I say all of your staff, really thinking about who are those folks that actually decided from a work-life balance situation, this is something that they want to do. The other thing that we're thinking about in our organization is we don't need so many offices. We don't need such a large floor in a building. Maybe we can actually bring that down, because there's going to be this blend of remote and virtual, and it could be potentially based on employee preference so that we can really help with their emotional state, helping them out. I think a lot of the sandwich generation, the young families, I think those folks really want to come back to work, that whole issue of trying to homeschool kids, real remote learning with their kids and try to do their job has just been way too much for them to manage. Okay, so let's talk a little bit about infection control. I tell you what, if we weren't really thinking about integrated physical health and behavioral health before this, I have a feeling that many of you are now. You're taking temperatures, people are wearing gloves and masks, people are distancing. You're really having to think about how do we have one entrance to our building. You have staff that used to go for a walk at lunch, and now they sometimes they don't want to because they have to come back through the whole check-in process. What are you doing about infection control? So if there's, we may as well prepare for sort of a fall-winter surge in COVID. Some of you are already seeing some of this happen. We're starting to see it in Spain and some of the places who got through it the first time. But what are you guys doing? So daily temperature checks when you walk in the door. I'd be curious whether or not you guys are using the touchless one, so you kind of put it to your forehead and you don't even have to touch. You don't have to change out different probes and things. So kind of what are you doing? Some of you are beginning to restock your supplies. This is really cool. 65% of you actually feel prepared. So I'm assuming that you've got gloves, you're restocking those supplies, you've got lots, more hand sanitizer. Hopefully you all have plenty of toilet paper in your organization. Hopefully we won't go through that fiasco again. Okay, so everyone gets a daily temp. And when I walk into my clinic, I get my temperature, I get asked about cough, shortness of breath. When I come in, there are masks, including N95s, on the table for us as staff to pick up, and there are masks for patients to pick up if they don't bring one in. You guys are going to have to think about what you're going to do if a patient refuses to wear a mask. We know that's become a bit of an issue in our country right now, and we need to really think about that. we need to really think about, what your protocol is going to be around that, if you're going to allow people in or not, and from infection control. And really, I would encourage you to use the CDC guidelines as you kind of think about what you're going to do. What are those guidelines for behavioral health? You can go right to the CDC website and you can pull those guidelines off. So in your strategic planning group, again, maybe you have a subset of this group that's in charge of infection control. I always say put a nurse in charge of infection control. This is what they are cut out to do and really feel comfortable doing. Okay, so if someone refuses to wear a mask, then they get teletherapy. Absolutely. And hopefully if that teletherapy was on the phone, hopefully having a way to do teleconferencing will be important. The touchless temperature, I really recommend that if you can. You don't have to really deal with all those extra supplies in terms of temperature taking. And sometimes that's all we had. In behavioral health, except for maybe the psychiatric medical team, we aren't used to this, and we don't take temperatures typically before you actually see any of your psychiatric team. We do typically weight and blood pressure, get that BMI. Those are the main things that we do. Maybe pulse, sometimes oxygen saturation, but rarely did we actually get temperatures. So adding that to a behavioral health clinic has certainly been interesting. And I'm guessing that some of you have, you're really thinking about your waiting room when people do come in. How spaced are they in terms of where they're going to sit and what they're going to do? And someone actually has a device to steam the entire building. That's the first time I've heard that, Brenda. And I'd be curious if there's a brand name or sort of what that looks like, and done again outside the waiting room. That's really cool. I haven't heard of that. And what the company's telling you in terms of that being effective. Deep cleaning the offices has certainly been something that folks are having to really think about, which means for you extra cost in terms of your janitorial staff, your custodial staff. So that's going to be an extra cost for you, as is all this PPE and your telehealth platform in the midst of COVID. And I understand there's some CARES Money Act, hopefully new money coming for behavioral health that will hopefully offset some of the costs that you're having. So take a close look at what you're having to do around infection control and really think about whether there might be some cost offset, especially in a time when you have limited, really potentially limited revenue coming in, which I think might be our next question, because we're really trying to get at, what's going on and what solutions you've had. Is your organization experiencing any financial consequences of the pandemic? So this will be our next poll. And really, what solutions have you found? So let's really kind of think about that. Has there been a problem? Yes or no? And then what's that sort of solution? What are you using in order to help you manage it? Let me give everybody a second to fill this in. I really worry about that. 2/3 or so of behavioral health organizations only had about 3 months of money on hand. So we're 3 months away from that, and I'm really curious what ended up happening to folks in terms of that. So let's just take a minute to answer this poll. And for the person that's hoping to keep their job, I'm wondering if that's related to finances, that because you've had a dip. Remember on our graph, we talked about that staff furloughs, staff attrition, what's going on. Is part of that because of the money? So over half of you are really struggling financially in your behavioral organization. Absolutely no one said no. So that is indicative, I think, of what's going on and how are you handling this. So let's just take a look in the chat box real quickly. Grant funding changes, and I don't know if that's state, foundation, or federal. Jane, you might want to, if you can just maybe talk a little bit more about which you're actually noticing. Trying not to worry about it. Yeah, because that's your administrator's, maybe that's your administration job in terms of thinking about that, doing the best you can. Yeah, the productivity requirements, really kind of thinking about what's happening with telehealth, how do I engage my patients potentially different. The peer home visits, I think, are extremely important in terms of keeping your billable visits up. You know, that would be a strategy for, number one, making use of that group that may have been more in office, having them go out to homes. But again, absolutely protecting your peer, your case management workforce if they do go out there. You know, having what's that going to look like? Are they going to stay on the porch? Are they going to go in the house? Are they going to hand the patient a mask if they go in the house, and what that's going to look like? You know, yep, really thinking about groups. How do groups bring in how do groups bring in that reimbursement that you need? You know, the job being, worries about your whole department, right, being eliminated. So we have this from Winston. We're finding different ways to provide care to clients since they're not all comfortable coming on campus, right? And as you're doing that, really thinking about your productivity. If all of a sudden your staff are seeing, 3 patients a day when they used to see 7 and run a group, I mean, again, that's going to really cut into your productivity. Okay, so again, more than half of you are really struggling with the productivity issue, with the financial consequences. And again, as we're moving in, we're 6 months in, and this is going to be longer term. All right, how do we strategize around productivity? Who's going to be in charge and looking for grants and watching for the next package that may come out of the federal government? And how do we tap into that? Again, as you're doing this strategic planning, as you're thinking about that, we're in this for a bit of a long haul. What are we going to do? What are we going to do about the finances in our organization? We know we knew we had the plummet. We thought it was going to come back up. It may not have come back up far enough. Now is the time, in your strategic planning group, is to really think, okay, this wasn't a short-term thing. This is longer haul. What do we need to do? And some of that may be the hard choices, eliminating staff, eliminating departments, eliminating certain things. In my organization, the first thing that went was CME, medical credits for the medical education for our clinical staff. I mean, right off the top, that's the first thing that went. So the cuts are happening in companies around the country. So to really think about what you're going to do. And again, productivity is where you make your money, and then grants and other assistance is the icing on the cake. I think we had 200 funding streams in my mental health center. I don't know how people kept up with all that, but we used United Way. We had all kinds of different things that we used. And also thinking about, are there contracts you might be able to garner, like corrections? I was able to pick up 3 contracts for doing services in the jail and detention center. So that brought in new revenue for my department. Is there something you can do around there? Can you start a MAT clinic? Can you start providing a buprenorphine for people with opioid dependence? That's something new. You can actually get your X waiver online now. You don't have to go to in-person 8-hour trainings for your physicians that may be interested. What are those other creative ways that you can bring in different funding streams? How many have done procedural cost analysis? That's a good question. And what does that look like in your organization? So again, sit down now. It's 6 months in. 54% of you are still having financial issues and concerns. What are we gonna do going forward about this? Don't think it's gonna go away anytime soon. We really need to plan for this. And again, I have stressed numerous times, really kind of thinking about strategic planning in phase 3 and not waiting and hoping that it's just gonna go away. So this is sort of our last poll, and I really want you guys to think about, what's that innovation or change in your organization that you are most proud of? So let's just try to see if we can put, what's that silver lining? What's that thing that's happened that you can really sort of pat yourself on the back and say, hey, this has been, we're really proud we did this, that we got through this. So people just take a minute in the chat box. This may take a little bit, just kind of think through it. I want you guys to kind of, on the positive side, what is the silver lining? What's happened that you're proud of? Yep, Brenda's talking about more self-care, and I have to say I've exercised more than I ever have. It's been it's been quite interesting what you actually do in your personal life. I've also done a whole lot of cooking. The ability of your organization to adapt, that your staff, that we're behavioral health people, we can be resilient. That quick transition from office to home. People did it almost overnight, but maybe within a week. 6 months of nonstop phone calls, yep, they're going to eventually go away, but they have been really good in terms of reaching people, expanding some services and materials to reach that broader audience, offering to healthcare workers a hotline or a warm line for them to call. People are just really proud of their staff and how they've done this work. They've been creative, adaptive, resilient, and reach deep. Just remember, as you move into, we're past 6 months, 8 months, 9 months, 12 months, how do you help them maintain that resilience? Getting food out to clients, that must feel really good, especially if you have your staff kind of bringing in food or others doing donations. Providing more services, because pre-auths were lifted. That's been really nice for us in Colorado, especially with Medicaid. And then just kind of thinking about, collaboration. People had to band together in your organizations and figure out how to do it. These are just great, guys. Thank you so much for sharing, and I see some positivity. Really, you want to figure out how to maintain that as you go through this process, because like I said, we're in it. So really make sure that you're doing some strategic planning and really kind of thinking about in phase 3, your finances, your workforce, your resurgence in infection, and what this is going to look like for telehealth going on. You guys are stronger together. Just you sharing in the chat box today, make sure you share your best practices either within your state organization, your local behavioral health organization, whatever that looks like. These things that you mentioned in the chat box today, many of them are things you can actually share with each other. So make sure you do that. The other thing I want to mention is that the Technology Transfer Center is going to be offering some practice coaching. This is the link that you go to if you're interested, and we're going to be looking at these COVID-related topics and really try to do some personal coaching. I'll be available for that. And we're going to do it for about 6 months. The time commitment for you is a monthly 1-hour phone call. Of course, you'll have some homework and things you want to do in between. Some of this could be your strategic planning process. It could be around telehealth. We want you to kind of go and look, and then we'll make some selections about who and how we can do that practice coaching over the next 6 months, and really welcome you if you want to further more of a discussion around this. So here's my contact information if you have any questions, and I'm going to turn this back over to the staff at the Technology Transfer Center.
Hi, yes, thank you so much, Dr. Rainey, for such a wonderful presentation. Again, for everyone that is interested in applying for the practice coaching program and looking at what that might be able to do for your organization, I have put that link that Dr. Rainey shared into the chat box. So please feel free to click on that link and give a look at the application if you and your organization are interested. Again, this program is open only to organizations and provider groups that are in the Southeast, so in those 8 HHS Region 4 states. So that would be the 8 Southeastern states. I think we have about 2 minutes, Dr. Rainey, for questions and answers. So all of you that are still tuning in, please feel free to enter a question into the Q&A box that you find at the bottom of your screen. The only question that we have entered in so far is about the work that you've done in the past, Dr. Rainey, with procedural cost analyses. I didn't know if you wanted to speak any more to that and your experience with procedural cost analyses.
No, that's really not. I'm a psychiatrist, and I just have to depend on my CFO to really sort of think about that. So that's not in my wheelhouse. Probably needs to be. But I'm just trying to think about, one of the things we could, potentially do is to think about that within the Technology Transfer Center and whether or not we could find someone with that expertise. Or I can also look at the National Council and some other organizations across the country to see if there might be others that have a better understanding of that than me. So great question. I don't know the answer to it. I think we're at the top of the hour. I really want to thank everyone for joining, and I look forward to the practice coaching with, those of you that get involved in that program.
Yes, thank you so much. I'll go ahead, since we're out of time, and share our final evaluation link. So we do have, as you can see on your screen, our SAMHSA required evaluation link. You can access that by clicking on this link provided on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events. Afterward, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There you'll have the opportunity to download a certificate of attendance for your records. So please allow about 5 to 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. Dr. Rainey, we appreciate you and your presentation and your willingness to engage in the practice coaching program with our center and with our provider organizations in the Southeast. We hope you'll all join us for future events, and that will conclude today's presentation.